Hi everyone, this is my second presentation on venous thromboembolism. Today I'll be going over in details what investigations that could be carried out. Okay, let's go. To start with, the beginning of your investigation as per making the diagnosis of venous thromboembolism from DVT to pulmonary embolism will be history taking. The history should include all the possible risk factors that I've listed while presenting the first time on venous thromboembolism. I will not go over all of them again. Kindly check my channel for venous thromboembolism risk factors. They are all listed. I think I listed more than 40 of them. Family history of first degree young relative with DVT or venous thromboembolism is crucial. If we could pick that, then we know we are dealing with a serious issue. Surgical history, like I've said, most patients admitted in the surgical ward and more importantly, orthopedic ward might come down with DVT just because they couldn't move around and maneuvering the bone and then all the structure inside and medical history like we've talked about renal failure, liver failure, heart failure, myocardial infarction, and so on. Social history like smoking, doing drugs, steroids, and medications, to mention a lot of them, thalidomide, asparaginase, and the list goes on. I've just talked about street drugs, alcohol, cocaine, and the rest. And unfortunately, because pregnancy is a good thing, pregnancy is also listed as possible cause of DVT that could progress to pulmonary embolism. And the past history of pulmonary embolism or DVT, which will be past history of venous thromboembolism, is a big factor here. So when the history is clear and we know what we're dealing with, then we're going to have what is called physical examination. With that, we'll have general inspection for signs of malignancy, like we look for lymphadenopathy, wasting of prominent zygomatic regions, and so on. And we check for ascites, hepatomegaly, case of hepatic vein, polycythemia. With that, we check for splenomegaly. Generalized edema in case of nephrotic syndrome, giving us a clue that there's problem with the renal system, and the features of pulmonary embolism. As a matter of fact, when we are dealing with anybody with DVT or we suspect DVT, we need to rule out pulmonary embolism as well. So, after history and physical examination, then we head to the lab. What are we going to do there? Okay, we take sample for complete blood count. Somebody is asking me, why that? When there is increased platelets, that is essential thrombocythemia. And that could also be associated with polycythemia vera. Decreased hematocrit will be given a clue that we might be dealing with malignancy with possible occult bleeding. Okay, later on I will talk about GAG fecal occult blood test or fecal immunochemical test. So also decreased white blood cell could be, now with that we might be able to say, okay, there's infection, not, and decreased platelets will be found in paroxysmal nocturnal hemoglobinuria, which is also a culprit as far as DVT formation is concerned. And decreased platelet could also be picked in a situation called heparin-induced thrombocytopenia. Thrombus is formed because the individual is on heparin for a long period of time, and decreased platelet will give us a clue. Also, still in the lab, we do peripheral blood smear. When we pick red blood cell fragments or schistocytes, that will be suggestive of disseminated intravascular coagulopathy or thrombotic thrombocytopenic purpura or hemolytic uremic syndrome. And peripheral blood could give clue to erythroblasts or myeloblasts. In other words, we'll be having the clue that we're dealing with bone marrow tumor. I've said earlier, malignancy is a risk factor. So with peripheral blood smear, we'll be able to know if there's malignancy affecting the blood formation lines. Now, we are still in the lab. The third thing we're going to do is coagulation studies. There's likely going to be increased APTT, and that will give a clue that we might be dealing with antiphospholipid syndrome. When there is increased INR, we might be dealing with liver disease. When there is increased erythrocyte segmentation rate, then we should be looking out for malignancy or connective tissue disorders. When we take guaic fecal occult blood test or fecal immunochemical test, the outcome might give clue if we are dealing with gastrointestinal cancers, okay, like colorectal carcinoma and the likes there. Liver function test to rule out any liver pathology, renal function test for the same reason to rule out renal pathology. We need to do the CT of the chest, or in addition, we can do the CT of the abdomen as well to know whether there's any problem along the abdomen or the chest region. Doppler of the calf, because that is where the DVT will be found most of the time. It could be at the upper limb as well, but mostly at the calf, the lower limbs. Arteriography could be done, or D-dimer to rule out DVT. When we have EKG done, that would be good, though not specific, not diagnostic when it comes to pulmonary embolism, but could give us a clue. And even with that, with EKG, you might be able to get what is happening as per myocardial infarction. Of course, we cannot make diagnosis of myocardial infarction alone. With that, we need the cardiac enzymes as well. Now, still there at the lab, we will now look for factor V Leiden and activated protein C. Protein C, protein S, erythrobin, antiphospholipid antibodies, for example, anticardiolipin and beta-2 glycoprotein 1 antibodies, and of course, lupus anticoagulants. Those three are antiphospholipid antibodies. When we want to get antiphospholipid antibody, that is anticardiolipin and beta-2 glycoprotein with lupus anticoagulants, we do all this, okay, day one, and we repeat them after 3 months. We should suspect antiphospholipid syndrome in young patients coming down with this, okay? And when there's raised APTT or unprovoked venous thromboembolism, you should be able to ask me, and I should be able to give you the right answer as per unprovoked venous thromboembolism. Unprovoked means there is no identified factors, risk factors, or situation that trigger this formation. Now, somebody is down with pulmonary embolism, DVT somewhere, the thrombus broke down, embolism occurred, and now you are in trouble. You saved the life, so you took the history, physical examination. Nothing is giving clue to why we have this. That is unprovoked venous thromboembolism. Paroxysmal nocturnal hemoglobinuria will present with urine hemoglobin, urine hemosiderin, and the urine cum test will help. We're not done yet. If you're suspecting whether there's liver problem or intravascular hemolysis, you are free to have haptoglobin, LDH, direct bilirubin, indirect bilirubin, reticulocyte count, and of course, complete blood count done. Peripheral smear for red blood cell morphology will be helpful. You can also test for hepatic vein if you are suspecting blood clotting, and you can just check the portal vein, mesenteric vein, and cerebral vein. And with that, I'm going to conclude as per the investigations involved in venous thromboembolism. Kindly subscribe to my channel because I'm going to talk more about treatment, DVT generally, pulmonary embolism, presentation, and treatment. Thank you.